All right, welcome back. Now, June is a critical month in the HIV and AIDS journey. This is because it was the month that the first couple of HIV cases were recorded in Los Angeles, California, in the U.S. 40 years ago. Now, we didn't know at the time, but that discovery marked the beginning of the first pandemic of the 20th century. Well, since then, HIV has killed 33 million people and infected 76 million others around the world. However, we've also learned a lot about HIV and AIDS, from prevention to treatment. And tonight we have a candid conversation on where we are as a country and what more needs to be done to make some meaningful strides in addressing HIV and AIDS in the country. Well, joining me in studio tonight is Dr. Catherine Ngugi, head of the National AIDS and STI Control Program, or NASCOP. Otoma, a national coordinator at the National Empowerment Network of People Living with HIV and AIDS in Kenya, or NEFAC. And virtually joining the discussion are Dr. Celestine Mugambi, head of technical support at the National AIDS Control Council, or NAC, and Professor Kenneth Ngure from the Jomo Kenyatta University of Agriculture and Technology. And he's also part of the Maisha conference team. We'll be talking more about that and what they seek to do during that conference in a couple of days. So let me begin with you, Dr. Ngugi. Just to kind of give us a situation analysis of where we're at. I know 2020 was a very critical year in terms of meeting certain targets, lowering the number of new infections, and also when looking at how many people are actually under treatment. Did we hit those targets in 2020, and where are we now?
Thank you, Badiri, and thank you for having us. 2020 years was a double pandemic for us, with the COVID and the HIV. In terms of putting the clients who are living with HIV on treatment, our target was around 1.2 million, and we were able to reach that target. Unfortunately, we were not able to, the new HIV, in fact, the new clients, the targets that we had, because with the 1.5 million people living with HIV, we have only identified 1.2, so we have around 300,000 that we have not identified. So we did not meet the target of the new cases to identify them. And as well, in terms of our children who are living with HIV, that we are still lagging behind in identifying them. And that's one of the areas that we're really putting in measures to ensure that we can be able to meet those targets. Yes, apart from maybe 2021, in terms of, I think you've seen it in the news, in terms of clients not being able to take home more than 1 month of the medication. It was a challenge, but we are really grateful that within the next 1 month, it will be something of the past, that as we are having more drugs coming into the country. But generally, we performed, we did well in 2020, and we are hoping that this year things will not change the answer, as our clients can continue accessing the medication, but as well being able to, if you feel like you need to know your status, identifying them. And as well, we had many innovations to ensure that we keep clients being able to access the services and using other, self-test kits. For example, a mother who comes to the health facility who is a HIV positive, then they're able to be issued with HIV self-test kit for the partner or the husband, so as to know. And as well as we used other means, like Ushauri platform, to identify clients, like if they don't want to come to the facility, and they need to keep in touch with their healthcare worker, then they're able to ensure that they are able to get more information to know how do they keep themselves safe, knowing that, at the beginning we had that anyone who is immune, suppressed was at risk of COVID. Thank you.
It's interesting, you mentioned last year was a double pandemic. We're in the midst of one right now, the COVID-19 pandemic. And Nelson, let me bring you in here, because when we think about the pandemic or epidemic of HIV and AIDS and how it broke out here in Kenya, 1984 was the first case here. When you look at the landscape of someone living with HIV back then and now, what has changed?
Thank you very much for having me back here, Vicky. And I should state that we in NEFAC, in as much as we are a non-state, we were founded, those who founded NEFAC were supposed to complement what the Ministry of Health do. And we were supposed to hold communities accountable by saying, please go and test, and if you test positive, adhere to this treatment. But I think the goals have shifted, so we are trying to hold the government accountable because you can't test, you can't have that regular medicine, and that's why now sometimes we turn and talk to the government rather than talking to the people who are supposed to take these services. But back to your question, I think there was fear. There was real fear, genuine fear, because there was no treatment. HIV had no treatment, and actually what we were not talking about HIV, we were talking about AIDS. Right. And AIDS was equal to death. And AIDS, is a cluster of all diseases, known and unknown, and that is the clinical stage of HIV. And there was fear because people were dying and there was no treatment. As we are talking right now, there is treatment that if people take in time, and the NASCOP tells us that the test and start, which means the moment you are tested, you need to be on treatment. And people who have been doing that have been able to restore their health, and they're doing normal lives and normal activities, and they have good quality of life. In as much as even we have COVID, even if they are infected with COVID and they adhere to their treatment, they're virtually suppressed, they're able to circumvent and live much better. So there is hope, except for a few challenges of where we have low stocks and also other issues. But I want to point out something that is persistent. Something that has always been there is HIV-related stigma. Even up to now, 30 years into the epidemic, people are not waking up to go and check whether they have HIV the same way you can want to go and check COVID or malaria or TB, simply because there is that fear still and stigma associated with HIV. And for key populations, to some extent, it is even criminalized, because you will be asked, how did you get it? You probably don't have this partner. So in terms of clinical manifestation, now people are all right, but in terms of social manifestation of the stigma, I think there's still that fear, and that is what is continuing to kill, particularly men and adolescents and young people. Yeah.
So how do you deal with it? How do you deal with the stigma? You're talking about 30 years of this same fear persisting. Now you're saying among men and young people, very critical groups. How do you deal with it?
We have just concluded, as part of responding to the stigma, what we call the People Living the HIV Stigma Index, where you have people have a discussion and a survey to say to what extent is stigma reducing. So I want to say that slightly it has reduced, but still strong among men, among professionals, and among adolescents and young people who are knowing. When they are children, they didn't know why they are taking treatment, but as they start relationship, when they reach teenage, they are realizing this is HIV, and I think that is impacting them. But I think we have groups like NEFAC, we have groups like WOFAC, KENWA, and International Community of Women Living with HIV, people who openly after testing go out to talk to each other. So it is through counseling, it is treatment literacy, it is education, it is all the things we do to make even COVID appear normal. It's the same thing that we make HIV appear normal, so that we encourage people who are newly diagnosed that in this country we have 1.5 million people, you are not alone, and these are the steps that if you take in terms of communication and reaching out and counseling, you reach the level of acceptance. I think the issue is acceptance, because once you accept, then you can even go back to that treatment.
Absolutely, and I think we underestimate how much of a factor accepting your status can help you kind of move forward and progress. Dr. Mugambi, let me bring you in. And I want to kind of go back to the basics, because during this pandemic, we've kind of been reminded of how important a public health threat is, or how serious it is, rather. And this has been going on for decades. We've just been discussing here with Dr. Ngugi and Nelson about how detrimental it's been over the last few years. But the fight hasn't stopped. And I want to hear from you in terms of just some of the key actions that are still needed to eradicate this, to make it a thing of the past, and to really address it from the root. What are some of the key actions that have been there, that haven't been hit quite yet, and that we can still kind of make progress on?
Thank you very much, Victoria. I'm happy to be on the program this evening. And let me just pick up from where Dr. Ngugi said that we have made a lot of progress in the HIV response in terms of putting people on treatment. I think where we are lagging behind is in new HIV infections. We've had significant decline from the peak of the epidemic by more than 50%, and currently we're at 41,000 infections. But I think in terms of what needs to be done, I think we can all learn lessons from COVID. COVID 2021, 2020, we were taught that we have to go back to basics of washing our hands, social distancing, and wearing masks. So in the 21st century, we're actually talking about washing hands, something as basic as that. It's important to understand that HIV is spread by behavior patterns. And to change behavior patterns, you have to go back and give information. And to understand that behavior is not formed in the health facility, it's actually formed in the family, in the community, and all the way up. So we have to go back to the basics and give correct information. What Nelson has said is very accurate about stigma, which is fueled by misinformation, lack of information, and a lot of fear. So we have to go back and inform the general population in a way that they simply understand, and looking at all the different categorizations of the population, adolescents and young people, men, give them correct information. I think we must also be intentional about taking prevention services to the community. Like Nelson again has mentioned, men. We know the health-seeking behavior of men is not that good. So we have to be figuring out as a national and a county program, how then do we ensure that we reach men with targeted information? And the same goes for adolescents and young people. How we communicate HIV, we have repeatedly been told it does not resonate with them. Their risk perception is extremely low, and if you look at how much they're contributing to the HIV epidemic, 42% of new infections actually are coming from the ages of 15 to 24. And that category, where do you find them? Which is my third point. We actually find those ones in the homes, in the community, in the school. So we really have got to go back again and rethink our partnerships, look at the critical sectors that we need to engage to ensure that information on basic HIV prevention is cascaded down up to household level. As we speak right now, even a child in kindergarten knows that they have to wear a mask, wash their hands, social distance. So why can't the same then be done for the HIV epidemic? So for us, those are the lessons that we have learned last year from COVID, and that's how we are intending to reprogram. Thank you.
Very interesting what you've mentioned, Dr. Mugambi, and I'll bring Professor Nguri in on that. In a year, we've seen the importance of, like you said, putting on that mask, social distancing, washing our hands. 1 year of sensitization. And how long have campaigns on HIV and AIDS been going on? And the message doesn't seem to stick. You know, the question then comes, when you're looking at the partners that Dr. Mugambi was just talking about, when it comes to government, when it comes to the implementing organizations and funding organizations, have they dropped the ball? Have they slept on the job when it comes to sensitizing populations on how to keep themselves safe?
Thank you, Victoria, and good evening, viewers. I think we have come from far, and we need to appreciate ourselves as a country. In terms of the progress we made in HIV, we are not learning from the field of COVID on how probably to communicate better, how to engage communities better. But the numbers that have been said by both Dr. Ngugi and others about like the number of people who are on ALT is 1.2. That is the second largest number of people on ALT in sub-Saharan Africa. When we come to prevention, for example, we have that has many tools. But the one probably I want to highlight, because all tools are important, is, for example, pre-exposure prophylaxis. In Kenya, we have close to 100,000 people on pre-exposure prophylaxis who have either initiated during their period of risk, which is actually a huge number, again, second to South Africa. And yet we don't have the second largest burden of HIV. So we've done well. We continue learning. Our prevention toolbox continues improving, and probably if we get time, I'll probably highlight what tools we have and the upcoming tools. So we can see a lot of light at the end of the tunnel. And probably the next few years, we are going to see the changes. And again, to recap what was said, is that the number of infections currently is a third of what we used to have, for example, in the mid-90s. Yeah? The number of HIV-related deaths is 64% less. It was 65% less compared to what we had in 2013. So we are making progress. So I'm more of an optimist on this. Thanks.
No, and indeed, the numbers are showing that. And I want to kind of bring up some graphics just to show the scenario in various areas of the country. So we talked about 1.5 million people living with HIV and AIDS in Kenya. And some of the high-risk regions when it comes to the virus load. We'll move on to the next slide there, Robert. And just some of the counties, Nairobi, Homa Bay, Kisumu, Siaya, Migori, and Mombasa, have a very high HIV burden. Let me come to you, Dr. Ngugi. Why do they still continue to hold that high risk burden when it comes to HIV?
Thank you, Victoria, for the question. It's a multifactorial for that region, and if you look into since the first case that was diagnosed in the country, the pattern of the high prevalences has been mostly in Western and Nyanza, and as well as Nairobi. But if you compare from the prevalence that we had almost 2 decades away and what the prevalence is right now, tremendous achievements have been made. There are, as I say, different factors in terms of some are socioeconomic, others are cultural, and as well maybe like in Nairobi, because of being cosmopolitan, have many other factors. For example, I'll give an example of in the Lake region, the fisher folk. I think you know about the issue of fish for sex. But I'll say even though that prevalence has been high in that region, we have really noted a lot of tremendous achievement in terms of reduction of the prevalence and as well as the incidence. And right now as well in Nairobi, even if the new HIV infections still are quite high, but we have noted the more of the clients and more of the leaders coming on board and being the ones who are advocating, even though yes, we still have the stigma, as Nelson has put it, and my colleague Dr. Mugambi, but we note that behavioral, if you look the pattern, looking into cultural issues, socioeconomic, and unfortunately, if you go beyond HIV infection, you go to sexually transmitted infections. When you look into the several studies that we have high number of sexually transmitted infections. But we move away from those regions and then go maybe to other regions for comparing like Wajir or Garissa. You notice the prevalence and the new HIV infections are a bit lower. But I would say, as my colleagues have said as well, that we have made tremendous achievements in those areas. Some are more than 29%. Now we are less than 13%. Wow. And really grateful for the many people who have advocated. But we know we still have work to do, because lately we have noted that is almost triple pandemic. Increased teenage pregnancies in those regions as well, coupled with high new HIV infections, but as well increased other sexually transmitted infections, especially chlamydia and gonorrhea, which we are really worried within the next couple of years, beyond predisposing you to acquire HIV infection, are really going to come on board. And more so, knowing our population, more than 60-70%, it is the young people. And when we visited one of the sub-counties, we were worried to meet more than 50 girls who have just delivered and have new HIV infections. So I think it's a time as a country as well, and that we need to address the issue of teenage pregnancies, issues of new HIV infections, which as well, when talk about increased mother-to-child transmission of HIV, it's among these adolescents, girls, and young women. Thank you.
And I want to go back to that demographic of the adolescents. And we had seen one of the graphics up there showing a big 42%, and that was the prevalence rate among 15 to 24, right? And then that stretches to 62% if you increase that bracket to 29,
yes,
right?
Yes.
I mean, it's extremely worrying. And Nelson, you mentioned how NEFEC began, and that was to talk to the communities. What are you doing? Are you doing your job to engage? So when you're looking at that 15 to 24 bracket, how are they being talked to now? How are they being, engaged, especially when it comes to education? I've also heard people talking about giving condoms as well and different contraceptives. Is that helping?
Thank you very much. I should have requested that you allow me to very quickly touch on something before I get into that. I know we are moving forward, but progress has been made, but there's one area where we are unacceptably not doing very well, and this is the area of preventing mother-to-child transmission. Mm-hmm. And just in 2019, there was a report that 8,000 and some figures on top, new infections were recorded among children, either through breastfeeding or birth or during delivery. And this is where you started, because we committed in 2010 that by 2015 we shall have eliminated mother-to-child transmission. We did not. We pushed it to 2020, and we did not. And actually it is going higher. So that is one area that is an indicator that we are not doing well. But these are children who are living into teenagehood and are now becoming, even some of them are even becoming mothers. Now back to your question. I think we have done well in terms of reaching out to adult persons who have HIV, less on young people and children. First of all, most of these people are in learning institutions. The learning institutions are restricted, and sometimes you find even teachers are not comfortable addressing comprehensive sexuality education and even educating their children. And most of the communities we are talking about, the parents could not have a direct relationship with their sons and daughters about sexual issues, and HIV is predominantly a sexual issue in terms of transmission. So the collapse of societal structures that would safeguard adolescents and young people have collapsed. They go to the school, and the subject of sex is a taboo. The most important person in a school is the school chaplain or imam. And they don't want to hear some of these stories being addressed in school. And I think parents probably are also shy and busy, and they don't have the skills to talk to young people. It is right now that we have started forming groups to reach out to young people on a one-on-one, because apparently they don't do the crowd thing. You can't call them somewhere and tell them something. You need one-on-one with the young people. And I think that will register progress. Right now, I also see the National AIDS Control Council trying to come up with Maisha Youth to address that prevention component of adolescents and young people, and it will be done through giving of life skills, treatment literacy and education, and also protecting the rights of young people, because some of them also get molested, whether in schools or at home, and even some of them also get HIV through incest. So it is protecting the human rights, but also giving the knowledge and life skills to young people so that they protect themselves.
I want to talk about, just mentioned prevention, Dr. Mugambi, and there's a question here from a viewer asking, why has it taken so long to find an HIV vaccine as compared to COVID-19? I know there's been a huge argument as to why several persisting diseases and ailments have not gotten the attention that COVID-19 has, let alone funding. But why do you think that has been the case? And also keep on that question, the issue of funding. I know there's been a global decline when it comes to funds for HIV and AIDS, at least from 2018, if I'm correct. But what has caused that, and what's the impact been?
So it's interesting that we always want to talk about a quick solution, a vaccine, without thinking about what fuels the HIV epidemic. And I said the epidemic is fueled by behavior. And behavior is patterned in the family, in the community, all the way up to the school. When you talk about, for example, the risk factors, which is poverty, lack of education, lack of information, gender inequality, SGBV, cultural practices. And all those we know can have actually a negative impact. So the issue of vaccine notwithstanding, and yes, a lot of research, a lot of progress has been made towards that, and Professor Ngure is the researcher here, he can probably give more information. We really have to go back and ask ourselves, why are we getting new HIV infections? And Professor Ngure talked about a toolbox. And when you talk about a prevention toolbox, a toolbox normally gives you options. So based on whatever has broken down, if it's your car, for example, then you pick your tool of choice. So when we talk about prevention, we have to go back to the ABCs of abstinence, being faithful, use a condom, know your HIV status. We've got now new prevention interventions coming in of PrEP, of the ring even for the women. We've got voluntary male medical circumcision. So those are the options that we need to package and give the population for them to make an informed choice, to pick the prevention option, which is most viable for them. And why must we do this? Because we simply cannot sustain the new number of infections because of the cost of treatment. You've talked about HIV financing. Over the last 4 or 5 years, we've seen a decline in donor funding to this country. And it's important to note that slightly under 70% of our HIV response is externally funded. And with what happened with COVID last year globally, we know what's happening in the global economies. So of course, that is further going to bring down the donor funding that we are getting. I was talking to a colleague of mine earlier, and they were crunching numbers, and they were saying for us to actually maintain the people who we have on ART right now, we need about 25 billion Kenya shillings per year. 25 billion, just to maintain 1.2. We have not even gotten everybody who we need to get out of our estimates onto the treatment program. We are still every year, right, as of 2020, 41,000 are entering that new pool. So we have to go back and seal that plug. So when we talk about prevention, I think we have to have very, very serious discussions in this country and really ask ourselves. I've had Nelson talking about comprehensive sexuality education, and I always ask parents whenever I engage them, who is the first teacher of your child? You're the first teacher of your child. A lot of young people actually are being ping-ponged between the teacher, between the home, the parents. So they are caught in a situation where nobody is giving them correct information. We also need to ask ourselves about teenage pregnancy. Where in the world is it okay for a 13-year-old girl to be pregnant? Dr. Ngugi has talked about they are the ones who really are increasing our mother-to-child transmission rates. So why are we okay with teenage pregnancy happening? I think we have to go back and think about issues happening in the community. And COVID really has brought them to the fore. We've heard about job losses during COVID. We've heard about increased cases of sexual and gender-based violence. Not all the children who were at home have gone back to school. So where are they? And what is going to happen? So I think it's HIV, I think, it's actually not a medical problem. It's a social problem. So we have to ask ourselves hard questions in the year 2021, ask ourselves some very moral questions in the year 2021, and really drill down to the basics of the community. How do we all take responsibility and ensure that we reduce new HIV infections, because we cannot sustain this response.
Certainly, when you're talking about 25 billion shillings needed just to deal with the current situation every year, is domestic funding an option if the donor funding is constrained?
So a lot of work has gone into that, and that really is our key mandate as the NARC, looking at sources of domestic funding. And we have seen increments right from the allocation from the national government up to all the way to the county government. So a lot of work is going on. I want to applaud everybody who's been part of that, but we're still not yet there. So we really have to ask ourselves, what then is going to happen if donor funding, for example, dwindles even further? And let us note that this 25 billion is not going to come from the skies. It comes from taxpayers' money. We are the taxpayers. So we are better off preventing HIV infections as opposed to dealing with a problem later on.
I know, Dr. Ngugi, you wanted to add on to that as well.
Thank you. Maybe on the part of the government, what is it doing regarding to sustaining the treatment of the clients as well, knowing that with the pandemic that happened last year, we know that most of the donors will maybe now move to COVID-19. And so over the past 2 years, we have noted that the government, and we are really grateful, have put in money not only in HIV programming, to a tune of 1.2 billion in 2019, especially the time you noted one of the drugs the donors withdrew, that is the cotrimoxazole. Yep. But mid last year, that the government committed to 3.9 billion for HIV, to fight HIV, TB, and malaria. And if you read you saw the budget that was read just the other day. 5.8 billion was allocated for the first time for HIV, TB, and malaria to fight in the country, which is a very big move, and as well a good commitment from the government to ensure that they can sustain the treatment and the fight and the response for the 3 diseases. So we note and have taken note of the donors funding dwindling, but we are grateful because we'll not be where we are right now if it wasn't the donors who really came into the aid of the country, not only Kenya, but as well within the sub-Saharan Africa. But I already want to concur with Dr. Mugambi that it's time for us as our country to take a hold more so of the treatment and some of the prevention measures, but as well as go to the public health measures that was there before, health education, strong leadership and from the counties, and as well as from integration of the sexuality education, but also noting that we need more advocacy. Talk about this over and over again. Before, you remember, it used to come on the news when you're being taught about HIV, you know, with those scary pictures. Now at least it has gone down, but I think we need to go back there. The same we are being reminded over and over again how to deal with COVID-19, because we still have a problem with HIV in the country. It's still an issue. Thank you.
Certainly, and I want to bring Professor Ngure here. Quite a few of our viewers interacting and engaging. It's a good thing. Let me take this question from Twitter. Truth Presidente asking, I think 42% of youth with new infections is quite alarming. Might the new wave or rise in, and I guess he means homosexuality, be part of the cause for increase because there's an increase in immorality witnessed? And I know this might come as a topic of discussion in the upcoming Maisha conference, if you want to take that, Professor, and also what you seek to discuss during that conference as well.
Thank you. Probably I'll take a step back and talk about the issue of treatment that has been mentioned by my colleagues there. And one of the things I want to say that 1.2 million people who are on treatment need to be maintained on treatment. We need innovative ways to make sure that those people are maintained on treatment, because research has shown us that treatment is also prevention. Once you treat people, and so even the remaining gap of 300, we're able to put people who have HIV on treatment and maintain that, we'll be able to reduce the risk of HIV transmission, thereby reduce the number of new cases of disease. So as we think about funding, let's also keep that in mind, that treatment is good for those who have HIV, but it's also good for prevention. And it's a very important HIV prevention tool. Now coming back now to talk about the question that has been raised about the HIV infections, rising HIV infections in young people. I think that has been one of the key things that is making many scientists, including myself, keep thinking of how can we deliver current HIV prevention tools to these groups. Because currently we have potent tools. We have our old ABC, we have the new biomedical interventions, we have structural interventions. So we have our toolbox is looking good and is even going to look better in the future. But these tools do not seem to have a very good uptake among the young people, and especially the young women. So we are taking a different approach, and this approach is more talking to the end users. And that's where, as Dr. Mugambi mentioned, behavior is key, and we are having a lot of people, even the clinical scientists, moving more into behavior, because we have learned there's one thing to manufacture a pill, is one thing to manufacture another prevention tool, but having motivating people on making them start and continue using that product consistently to reduce HIV infection, that as a scientist we may not be able to know. So the best way is to talk to the end user. So these days we are partnering a lot with young people, young men, young women. We are listening more than talking to know how best to deliver. I'll give you an example. When we talk to young women about HIV, they have told us HIV is a problem, yes, but unwanted pregnancy probably is a bigger problem for them. So the scientists working together with product developers are coming up with new tools known as MPTs, that is multi-purpose prevention technologies, where you're going to have, for example, that ring that was mentioned by Dr. Mugambi, that has dual purpose. It has a contraception and it has a HIV prevention component. That probably, once you address those two challenges of the adolescent women, probably will see a higher uptake. So that's one of the things. Now coming back now to the upcoming Maisha conference. First is to thank the National AIDS Control Council for formulating this Maisha conference, even amidst the challenges that we are having, because this is going to provide an opportunity where both the communities, starting with the communities, then going to the scientists and policymakers and others are going to meet together and cross-pollinate ideas. The scientists, for example, would share the latest findings in the fields of HIV prevention, HIV treatment, including the innovations that have been developed during delivering HIV medications and prevention medications during COVID. Those have been piloted by some clinics, and they're going to be shared to the wider group. So it's going to provide a very good forum where everybody is going to share their experiences, what is working in communities to address stigma. Then based on that, is we are all going to work together and develop country action plans that can be now implemented. And thankfully, having a conference within a specific country is quite good, because then you're able to develop local, you listen to your own science and develop your own solutions, yeah, which is then quite relevant as opposed to getting a solution from another country. So you're going to have our homegrown solutions to address the HIV pandemic. And that dream is that we're also going to recognize in the same conference, we are going to recognize our global and Kenyan scientists, because our scientists are doing a lot of good work that is being recognized globally. Yeah, and they have also done a lot of work locally, which is also good that they're going to share, but they're also going to be recognized and get some awards. And not only the older scientists, but we're also going to get the young upcoming scientists, because we want scientists to continue developing locally relevant solutions to the current HIV pandemic. This conference is going to run for 3 days, starting Monday. It's going to be virtual. It's going to be the largest virtual gathering to discuss HIV. And at the end of the 3 days conference, we will be having some action plans that are locally bred and locally relevant. So I'll pause there. Thank you.
Fantastic. Thank you, Professor Ngure. Very diplomatic. And it's certainly music to my ears when I hear you gunning for homegrown solutions. We certainly are capable of finding our own solutions when it comes to an issue like this. Let's head over to more questions from our viewers. This one now coming for Nelson. And The Anointed asking, does age consent have to do with the increased cases of HIV infections amongst teenagers and adolescents? How do the two correlate? And what is your comment on this?
Thank you very much, and thanks to the person who has sent that question in, and also issues of young people and their infections and even their AIDS-related deaths would be part of the Maisha conference on Monday and Tuesday. And I assume he was talking about age of consent, but I need to clarify that. First of all, we are talking about adolescents and young people. Adolescents, part of them are children up to age 18. By Kenyan law, those are children, and marrying children or having sex with children is something that is illegal. But they say that kwa ground vitu inakuwa different. So we are likely to find children who are people's wives, children who are parents already, and so on and so forth, because people already broke the law. We are operating outside the law, and I don't think we can arrest all of them, because there will be no space for all these people. So what we are talking about, let us go back and give to children what belongs to them. Let us help the government to protect the children away from all this sexual health risk, whether pregnancy or HIV. And when they reach the age of consent, when they become adults, then they have the choice. Now that choice need to be informed so that they have the knowledge and skills to negotiate, to stay away from danger and risk, and also to make sure that they are capable of taking care of their lives. Some of the young people, and majority of young people who actually have HIV, it is out of molestation. It was not out of their consent. It was out, they were lured, or sometimes they were defiled, or sometimes they were raped. And the law was silent, because parents probably conspired and didn't take it up. So we have to go back and sensitize the parents that where a teacher, pastor, or adult in position of authority molest a child so that a child has HIV, I think that is criminal and should be taken to the courts of law. But for older adolescents and the young people, they have the choice, but what is important for them is to know the consequences. They need the education, they need the life skills, and they need to be kept out of poverty and suffering so that they don't see sex as something that can help them survive, because some of the arguments is that hunger will kill you the following day, HIV will kill you probably in 10 years. But that is where social protection comes in. We need to address HIV prevention as not just a clinical or biomedical thing. We need to give these young people the school fees, the bursaries to go to school, yes, and we make sure that they have the food, they have the clothing, they have the sanitary pads they need, and they stay away from poverty. Yes. And that is now the responsibility that we are pushing back to the state to take that up, so that we don't just say HIV prevention, that we give condoms or we we give medicine, because for people who have HIV, the moment you adhere to your treatment, like Professor Ngure has explained, you will not pass on the virus. But for these young people who are still struggling with their life, I think we need to keep them in school. And when they're at home, we need to protect them with the law and make sure that they have the daily needs so that they don't go out of, they go looking for danger. Thank you.
Couldn't have said it better myself, Nelson. Being practical in the approach, if nothing else. Thank you so much for your time. We are out of time, speaking of which. Thank you, Dr. Ngugi, and to Professor Ngure and Dr. Mugambi for your time and insights. A lot can be said when it comes to this discussion of HIV and AIDS in Kenya, but good to know that we've made progress and we continue in the fight, be it from informing more of the population on what they can do to protect themselves, getting more funding, and getting more people on treatment if they find out their status as a positive. And most importantly, dealing with the stigma. You're not alone. Several groups exist to help you walk this journey. Thank you so much for watching Citizen Weekend. I'm Victoria Rubadiri. Stay tuned though. One Love is coming up next.